Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for clinicians in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. This podcast is about documentation in emergency care. My name's Chow Yen and I'm a medico-legal consultant at MPS and I'm an anaesthetist in Auckland. I'm very lucky to have with me today Dr. Tim Cookson, retired medico-legal consultant and GP, and Adam Holloway, who is one of the partners at our panel law firm, Watton Carney. Hello, everyone.
Hello, Chow Yen. Thank you.
Hi, Chow Yen.
Hello. So today we're discussing a situation that many clinicians in ED, trauma teams, primary care will be familiar with, managing the patient who has been assaulted and the complex path that sometimes leads clinicians from the bedside to having to present in court. So whether you've had to give evidence in court, write a medico-legal report, or just pause while documenting to wonder, how's this going to come across? Please consider what we talk about today. So let's start at the beginning. Say a patient presents, perhaps in acute distress, disclosing that they've been assaulted. And you're taking their history, examining their injuries and planning their care. And at the same time, you've got to give consideration to the medico-legal process. One key issue is language in your documentation. One of our listeners has asked us, should you write alleged assault? Now, some of my ED colleagues have raised that this gives the impression that you don't quite believe the patient because it's alleged, and that it's more neutral to write the patient states they have been assaulted or the patient reports they have been assaulted. What do you think, Tim?
Yeah, look, as a doctor, I think that the wording alleged assault sounds awfully legalistic.
Yeah.
And I think you've changed what ought to be a clinical note into a legal document, which is not, I think, appropriate in ED. And I think, we can take a step back, and I don't think even we need to say the patient states or the patient reports, because when we're writing our notes, if we're following the standard format, which is history, well, history is automatically what you obtained from the patient, or if you've obtained it from another person, you would record who you've obtained the history from.
Yes.
So it's quite clear from a clinical point of view where that information has come from. That, I think, is different from when, if you're asked to write a report or an affidavit for the court, then that's when the wording needs to change. And so I think it's perfectly appropriate in the notes to say, yes, that there was a history assaulted, and it may be important to note who the person was who did the assaulting, because that could have some clinical implications, or, so for example, you may need to organise a protection order for a patient who's been assaulted by her partner.
Yes.
So you need to know who the alleged assailant was. But I think for me, the important bit is you write what's clinically relevant in the notes for the hospital bit, and then it's a different thing that would be done if it goes to the court. So you wouldn't just be handing your notes over willy-nilly. The court would get your notes, but they would also get the report, which is worded differently.
Yeah, so you're making that documentation as a doctor seeing a patient.
I think it's really important that we don't blur that edge at this stage. Yep. Yep. Your thoughts, Adam? You see too many doctor's notes that actually aren't helpful.
No, I completely agree. I think you're more likely to trip up if you're trying to think 3 moves ahead and imagine yourself in court. Your job is to provide care, to be a doctor, and to do that in the ordinary, competent way that's expected. I don't think that it's incumbent on doctors to ring-fence a special group of cases where they start expressing themselves differently. It is, as you say, Tim, history is what the patient has reported to you. If you did want to write the patient reports, that's absolutely fine. I think it would be unnecessary and awkward, or potentially upsetting to the patient to write alleged assault in the notes. Absolutely fine to write down what they've reported reported to you.
Yeah, and it is certainly important to make all your documentation really clear and objective. For example, there was an HDC case where documentation was noted to be a problem. Are you able to talk us through that, Tim?
Look, I can't think of one podcast that we've done where we haven't mentioned how important documentation is. So at the risk of hammering that again and again, it is just the basis of everything that we do. We need to have clear documentation. It has to cover the important positive aspects, important negative aspects, but it doesn't have to be war and peace. It shouldn't be 5 pages long. It needs to be succinct and appropriate.
Yeah, absolutely. And along in this context, there was specific to this topic an HDC case where an ED physician documented 1.5 lines only when a patient came in after being assaulted, and they were criticised for their lack of documentation.
And quite rightly, and that case I think was from some time ago, and my impression of having read lots of ED reports since then is that they're generally exceedingly full and cover everything. Now, obviously there are time pressures in ED, and you may be spending a lot of time with your patient. Your initial write-up may be briefer, and it's absolutely fine to go back a bit later when you've got a bit more time and complete your documentation.
Yeah.
I noticed that you mentioned there positive and negative findings, and perhaps this isn't so specific to the fact that in the context of something that may be examined criminally, it's going to be helpful both to the people investigating that and to your patient to, as in the HDC case we mentioned, have a good, a fulsome assessment of precisely what the injuries are. But it is really interesting how often important negative findings are not documented. Mm-hmm. And when you get to the pointy end, for example, in a coroner's case, if we're dealing with a patient who's presented to ED but gone on to pass away, and you're taking a doctor into an inquest and you're trying to make the case, well, this thing, for example, a serotonin syndrome, wasn't apparent to me at the time because I did not see XYZ sign. But the fact that key or cardinal symptom wasn't seen at the time hasn't been documented, and it becomes so much more challenging to paint a sympathetic picture when you are getting the doctor, your witness, to look back 4 years into the past and say, I can be really confident that I didn't see that because if I'd seen it, I would have written it down, is never as good as a set of notes that say, in my differential diagnoses, I have considered serotonin syndrome. I have looked for the following indicators. They are not present.
And I think that the kind of the intellectual exercise that we all do when we're operating really well is we think, what are the things that I'd most like to be sure are not occurring, and have I done sufficient to exclude those? And if you think there might be 2 or 3 important things that you want to say, I've looked for those, there's no signs there. Child who presents with a high fever, you've looked for and recorded no neck stiffness. Absolutely basic, really important clinically, but also, as you say, Adam, if it did turn out to be a coroner's or some other legal process that was being followed.
It's like doing maths, doing a maths exam. You can't just write the answer. You have to go through the process of working it out. Because if you write down the wrong number, you can still be marked on your process process through it.
Well, show your workings.
That's right.
And I think that's right. I mean, we can go through the right process clinically, but still actually end up with the wrong diagnosis because either that we didn't have all the information that we needed or whatever, but we've come to what we thought was the most likely diagnosis. And if we can show that our thought processes were logical and that the conclusion that we came to fitted the information that we were given, then I think we're going to be judged much more fairly than if things are out of kilter and there are bits that don't make sense and missing.
Indeed, and you can just have unusual presentations. And
Absolutely.
You can be in a position where it's completely understandable to have missed the diagnosis at that point in time, because it was presenting in a rare or odd way. But if you've diagnosed that you looked for it, it's going to ultimately play much better for you if that is subject to some scrutiny later on through a complaint or a coroner's process.
Yeah, and going along with the whole coroner's process, scrutinising the care provided, one of the common things that come up is, you've gone through, you've examined the patient, taken a detailed history, documented clearly, but then something untoward happens and your documentation is scrutinised and they say, well, in this assault patient, they came in with a head injury. The ambulance reported in their paramedic note that they had vomiting and dizziness, and you didn't mention anything about that. So then you get lots of questions about whether you looked into it or not because you didn't comment. So once again, that important negative, I reviewed the ambulance note or that triage note stated X. This was not present when I examined the patient, or they did not report this when I examined them or saw them.
Yeah, I mean, it does highlight the issue that actually you do need to read the information that's there before. And we've had so many cases at MPS where clearly that didn't happen and therefore wrong assumptions were made because that information, just wasn't part of the thinking process.
Yeah.
And although it seems like a bit of a pain and you're thinking, oh, I'm too busy, I haven't got time to read it, actually you haven't got time not to read it.
That's right.
Is the key. And then, as you say, if there are discrepancies, then that's vital. Not only it's vital clinically because that if there are discrepancies, you need to think, well, why are these discrepancies, and think about that from a clinical point of view. But I'm sure, as Adam would confirm, if the discrepancies are not addressed in the notes, and then there's a legal process, that is going to be a focus of attention.
And often, it's a busy environment. If you can't find the notes, you can state that notes were not available at the time, that the paramedic notes or the ambulance notes weren't available, or the triage note wasn't available at the time that I saw this patient.
Mm-hmm.
So, Adam, do you have anything else to add about the importance of clear documentation?
Yes. So while we've talked about the fact that your role there is as a clinician and to provide care, and that it's really the most important thing, there will be cases where it may be apparent that what's happened will be investigated by police, or if the patient is reporting that their injuries are the consequence of a crime, that may ultimately be something that finds its way to the court. And while that's not a reason to suddenly change the language that you're using, I think it is worthwhile to pause at that point and think it's perhaps, of all the cases, particularly important to write sufficient notes that you're going to be able to speak about this case in 6 months' time, a year's time, when you may not remember the patient anymore. Criminal processes can drag on. It can be a while, and in fact you may not be involved at all, and then suddenly you get a subpoena from either the prosecution or the defence saying that they want you to attend court and give evidence about the care you provided to this person on that evening. And should that happen, it's going to be a lot easier and a more straightforward experience for you if you've got good comprehensive notes that you can look at and can say, well, I don't have a particularly clear memory, perhaps, of this case, but I can see from my notes that X, Y, Z, and you can go through and speak to it if you need to in court. So that is a reason to turn your mind, I think, perhaps, to, is this a sort of case that where my notes might be needed in another forum? And rather than just being consigned to being part of the clinical history, might I be called up at some point in time in the future to explain these? And there's a good reason perhaps to try and be as comprehensive as you can without, as Tim said, writing War and Peace.
And are you suggesting, Adam, that in the court situation, not all of the lawyers involved will necessarily be kindly disposed to your evidence and may try and find sort of weaknesses or flaws in what's there?
Yeah, that's exactly the case. You'll be called for a reason, and there'll be something about the case that means it's important to have first-hand evidence of what you observed that night. And whichever side is calling you to give that evidence, you can assume that there's at least a good chance that the other side are wanting to make the opposite point, or perhaps find a reason why the decision maker, the judge or the jury, if there is one, shouldn't put weight on what you have to say. So I think, to be fair, in the majority of cases where doctors get called up to give evidence, it's pretty uncontroversial and you're in and out, but you can't guarantee that. And part of going to give evidence is that you make yourself available to be cross-examined by the other side.
Right.
So in summary, I guess then you're saying, yes, it's always important to have full documentation, but if you know that there's likely to be a court case, you probably want to be extra sure that you've got full documentation, and maybe even thinking more about the relevant negatives that you might want to put down that you wouldn't maybe not always think about from a clinical perspective.
Yeah, I think that's fair. And just to take that pause to be the best version of yourself in terms of your note-taking. If you are writing down what's been reported to you, then make sure it is under the heading history and that you're not seeming to, for example, adopt the perspective or express your own opinion that this person's clearly been beaten, for example. Be quite regimented. This is the history. This is the physical assessment. Here's my plan. Here's the treatment that we're going to offer, or the referrals that we're going to make. Just keep it nice and tidy, I think, would be my advice.
Yeah, so it comes across that if there is a process to follow, then it's important to follow it. For example, I've looked through, and there's a case where, from a while ago, a GP saw a patient a young girl who had a sexually transmitted infection of gonorrhea, and the child reported that they had been raped, and the GP didn't refer her for further forensic examination and just stated in his documentation that she had been raped. And when the case actually progressed and went to court, he was later criticised for not following due process and making an assumption, not referring her for proper assessment and making an assumption.
Yeah, I think it's understandable that there would be criticism on that scenario. Being such an important and delicate matter, you would expect a referral to the right team of people to get involved if there's been if your patient has reported to you as a minor that they've been raped. But even, Chow-Yen, what you said about the way the note's been articulated, where the GP has just said, presented, obviously I haven't seen the note, but this child has been raped. At that point, the doctor is not expressing a history of what the patient's reported to them. They're expressing a conclusion. Yeah. And you can imagine how that might play out subsequently in criminal proceedings. There'll be one side that wants to make hay out of that conclusion, perhaps if they're able to technically, and say, well, this doctor thought the child was raped, and you'll have the other side making some, I would have thought, quite robust and valid criticisms about expressing that as a conclusion. Because if I was a lawyer for the defence, I would want to know precisely how that conclusion had been reached, on what basis, were the right guidelines followed, were the right interview techniques used for such a young person, were the appropriate examinations conducted, what evidence was gathered, what was seen on examination in order to allow the doctor to reach that conclusion.
Yes, and although some of the teaching around that is that any minor with a sexually transmitted disease, that automatically equals some illegal activity has occurred. Yeah. It's still not right, as you say, Adam, to make that assumption without absolutely confirming it and not referring for an examination. So the GP making lots of assumptions and recording those assumptions as conclusions is clearly a dangerous position to be in, and very vulnerable for that GP having done that.
Excuse me. And talking about process, there's also photography and clinical photography and forensic photography to be considered. There is an ASIM policy, Australasian College of Emergency Medicine policy, and that applies across all emergency departments in Australia and in Aotearoa, New Zealand. So if you're interested, you can have a look at that. But what that states is that as clinicians, we can take clinical photographs that help with our care and treatment. For example, patient presents after being assaulted, they might need a referral for, let's say, plastic surgery. And so we take a photo to make that referral to our plastic surgical colleagues. That photo has been taken for clinical reasons, but later on it may be used in court as part of the evidence. Does that sound reasonable?
Yeah, I have to confess, Chuggy, I haven't read the ACEM policy. But speaking from first principles, again, your job is to provide clinical care, and it's quite normal to do imaging in connection with clinical care, and photography's a type of imaging, and it can you can do it or need to do it for clinical reasons, being referrals, etc. Quite normal. If you're thinking, I'm taking a series of photos because this is evidence that might need to be captured, I would pause at that point and think, am I the right person to be doing this? Should I not be involving the police, who not only, I'm assuming, have forensic photographers with their own sorts of training and techniques, etc., but also their own chain of custody and I imagine quite deliberate and thorough ways of documenting things that will make that evidence easier for the prosecution to ultimately use and more reliable. So I don't know if that's consistent with what the ACEM says, but that's my first thoughts anyway.
Yeah, absolutely. So there's the clinical photography that the clinicians can make for clinical purposes, and the forensic photography is done by the police, unless in some rural parts of Australasia they can specifically request the hospital clinical staff to take the pictures for forensic purposes. But as with all photography, especially clinical, because we're taking it for clinical reasons, you really need to store it appropriately. So not in your personal phone, not via WhatsApp, properly secure platforms that are approved by your hospital, and you need to make clear documentation that you've taken the photos of what and for what purpose and how it's being stored. Does that sound reasonable interpretation?
Yeah, I think that does sound very reasonable, and it's such a temptation, isn't it, that we carry these devices around which have very good cameras on them, and it's very convenient to take a photo. And I'm guessing that in the real world, every night there will be registrars taking photographs and WhatsApping their consultants to help make the decision as to whether or not the consultant needs to come in. That's its whole other thing. I guess I'll say at the end of the shift, please delete all of that from your personal device. But in the realm of what we're talking about, where there's a suspected crime, then it's really essential that it's done the right way. And I'm guessing that most EDs will have a system, and perhaps a device or a camera that is going to be then uploading its photos into the hospital clinical record system, rather than your own phone, which, all sorts of things can go wrong. For example, it's quite common for WhatsApp to be connected to your iCloud or your Google Photos, and you are rapidly losing control of that really sensitive clinical information.
Certainly a big area of vulnerability, I think, because it's so easy to take a photo, and if you don't think about those consequences, and as you say, if you don't every day delete the photos and get rid of them, then they're going to be potentially available. And the other side too is that if you are taking the photos mainly for a forensic purpose, then if you don't have the skills to make sure that the photograph is actually able, sufficient quality and has the right information, then you've wasted your time, because it won't be good evidence in court. You're taking a photo of a bruise, but you haven't put a ruler beside it to show exactly the dimensions of the bruise, which may then become an issue. So as Adam said, much better to get people who know what they're doing for that purpose to take those photos.
Yeah, and I imagine that if you don't follow the right rules and processes, and there's a breach of patient privacy or a breach of your hospital regulations, there'd be significant ramifications there too.
There's certainly a risk. So that's photographs, but of course there are other sorts of physical examinations that may be what we call forensic, particularly where there's someone's reporting a sexual assault.
Yes.
And what does the ACEM policy speak to those as well, Xiaoyun?
Not specifically. That policy specifically talks about photographs, and how to approach photographs in a situation where there's a forensic component beyond clinical care.
I think in their core principles, they do talk about forensic examinations not being standard ED duties.
Yes,
and therefore that wherever possible, those examinations should be done by the most appropriate specialist. So, a registrar in ED who sees a young person who's alleged sexual assault, it's going to be much more appropriate for the most senior clinician available to do that with a clear view that this is going to become a legal process as well as a clinical process.
Yeah, and I think that that gets us to is, and I see that this is consistent with the view of the ACEM, is that the care you're providing, the emergency care, that's always the priority.
Yeah.
First and foremost, you're treating a patient.
Absolutely.
That ideally it's not your job to do the forensic work, but of course there will be situations where it's unavoidable because of staffing issues that you do end up gathering information that has some forensic relevance, in the sense that it does need to form part of the evidence that's ultimately relevant. But ideally, if you're doing that frame shift from being a doctor to being a gatherer of evidence, that job's being done by someone who's trained to do it, because it is a fundamentally different job from providing healthcare, and often there'll be a lot of very careful processes around, if you're collecting samples, for example, labelling, custody, how you handle things, that are all designed in a way to make them much less vulnerable to potential criticism down the road from a defendant who's trying to make the case that, you know, that sample's been contaminated or what have you.
So if a sample has been contaminated, does that mean it's not admissible, or what's the outcome of?
Yeah, I don't think there's an easy answer to that. Every trial will be different, but you know, it's the job of lawyers who are there to defend people to make the case that there's not enough evidence to prove this beyond reasonable doubt, and they'll do that however they can. And that if that includes suggesting that, you know, it's the Crown witness who's been called to say that, you know, this sample taken at this time at this place, and suggests that it included material that could only come from, you know, this one person, and there's a reason why you can try and prove that's not true, that they'll do it, and they will not hold back if the way they achieve that objective is to have a crack at the doctor who's needing to turn up and give that evidence.
In the scenario, particularly in ED, but it could also apply to general practice or to after-hours centres, I think where there's been, you know, clearly a major injury and there's been an allegation of assault, then the pathway is reasonably clear. You automatically think, I need to get the right person to do it. The trap was probably going to be in the much more minor ones where the incident is pretty minor, you know, the very little in the way of clinical intervention is needed. There's no question at that time that it's going to be a legal process.
Yeah.
And then, you know, 6 months later you get the call, oh, well, this is going to court. You think, what?
Yeah, that's right.
How did that work? And that's where having your basic documentation being, you know, of sufficient quality is going to be really helpful for you.
Oh, yeah, you're right. Because if it's a full-on process where you're having to think about taking photos and involving the police from the get-go, then it's obvious. But if it's a small laceration, then your thinking might not be about clear documentation. So then going along with that, if you know, if you see someone, like you say, for a consultation in urgent care and they've come in saying that they've been assaulted and they've been hit in the head, and what they're reporting are quite subjective symptoms, like, oh, I've just been having headaches, and, you know, after I was hit in the head by X, I've just been not quite myself. I've been a bit forgetful, headaches, just feel a bit foggy. How do you document that sort of subjective finding, Tim, would you advise?
Well, exactly as you've said, that they're subjective, the patient's reporting them, and, you know, that is valid evidence. You can't you may not be able to test it, but you ought to make attempts to test it. So, you know, arranging psychometric testing, you know, doing something that's appropriate to see if there really is some kind of cognitive impairment as a result of the injury, and that's certainly possible. There are the kind of tests that the sports physicians do, for example, looking at concussion in the early stages. I understand now that there may even be a blood test that's going to be available, and that'll be really helpful. when you can do that sort of thing. So I think that the medico-legal risk would be that, the subjective stuff, that's fine, you just reported that. But if you haven't done the appropriate stuff to then investigate according to the seriousness of those reported things, that's when you're going to be more vulnerable.
Yeah.
Although I would say that the standard is still the medical standard. You're not your job, I guess, to try and make the case that that this person's been assaulted or the severity of that. You still have to come at it from a medical lens, and in an environment where you're triaging and you've potentially got only so much care you can provide, then if you would not do those sorts of tests for someone who, for example, reported that they'd knocked their head on the car boot door, I don't think there's a reason to do it for the person who's reporting exactly the same symptoms but say that it's because someone punched them 3 weeks ago. What do you guys think about that? Agree or disagree?
Oh, look, I agree. It is a clinical decision.
Yeah.
And I guess what I was trying to point out was that, if it did come to a complaint or whatever, that's where the medico-legal vulnerability will be, is if you haven't done the appropriate clinical things to ensure that you've covered the possibilities. So the person who's still getting headaches 3 weeks after an injury of whatever kind, if you're not thinking, well, could there have been a subdural, this is an 85-year-old who's clearly at risk, then yes, you're failing your patient by not doing appropriate investigations at that point.
But if they're subjective presentations, then you can document that patient presents with headache. These are subjective findings and could suggest concussion, which is a clinical diagnosis in some cases.
Yes, well, concussion itself is a clinical diagnosis. That's right. Yeah. But there may be other sequelae from the injury which are not concussion, but much more serious. No, concussion itself is a very serious diagnosis,
but then
with
you
long-term implications.
That's right. So, but it's reasonable to write, even though you don't have anything objective. Let's say there's no one test that you could do to diagnose this, but the patient still has subjective findings. It's still okay to write that this is a subjective finding based on their report. It's a collection of symptoms that's subjective. And in your documentation, you'd write this is subjective. It's not, I can't do one test to diagnose it.
I'm not sure that you need to do that.
Okay.
And I think so long as it's clear that you've taken the history, you've done whatever the appropriate examination is, and the examination findings may be completely normal, you've decided that no further investigations are done, I think it's perfectly reasonable to say provisional diagnosis, concussion. If it became a court issue and you had to write a report, then you might want to clarify that diagnosis was made purely on the basis of the history that you obtained. But I think from a clinical point of view, you don't need to be thinking about whether you need to record this as a subjective diagnosis or whatever. I'd be more pragmatic, I think, in my approach.
I think I'd agree with that. It's to say provisional diagnosis, concussion, have given appropriate advice about rest and recovery, and to come back if symptoms evolve is very...
Safety netting is always very important.
Yes, very reasonable.
Just as a nice little aside.
Reasonable approach. Yeah.
So just another question that we often get is if the information, for example, in a sensitive case, and you're being asked in court to give some information about the patient that you saw, and you don't have the consent of that patient to discuss the sensitive information, how do you approach that? If, for example, you have to write a report on a case where patient's being sexually assaulted and it's sensitive and you're not sure whether they've given consent, could you just write not giving consent to discuss this?
It depends a little bit on the context, and particularly when you talk about writing a report, sort of what stage things are at. But at the end of the day, once you're in court, it's fundamentally not going to be your job to manage those worries. Your job is to answer the questions that are asked of you. And if there is, it's absolutely fine to say, turn to the judge and say, well, to answer that, I'm going to have to talk about a history the patient gave me the year prior. Is it okay for me to do that? If that makes you feel more, protected and respectful. But it's really up to the parties and the judge to control the evidence and to make decisions. Well, the judge will make decisions about what's admissible and what's not, and what should or shouldn't be said. But there are other contexts within which those considerations might come up. So, for example, one that we do deal with from time to time is that you will get a production order served on you to provide all of your notes in respect of a patient. And often this is with psychologists. So somebody has reported a sexual assault. Subsequent to that, they've been having ACC-funded counselling. Sometime down the track, the person who's been accused of perpetrating that assault is coming to trial, and the defence will seek all of the counselling notes, which of course are very sensitive, and the provision of those notes risks really damaging the therapeutic relationship between the counsellor and the patient. And there is a process that it's probably a really good moment to call MPS, if you remember, because there is a process to follow where you can alert the court to the potential difficulty with disclosing all this material, and there will be sometimes another independent sort of third lawyer who the court appoints to review the material and make decisions about what needs to be disclosed to ensure a fair trial and what actually is just private information that has no bearing on the trial and there's no need to disclose. So we do get those sorts of things coming up. I think if you're in court, in a sense, it's quite easy. You just do what you're told.
Yeah.
If you're outside of court and you're being asked to hand over information about your patient to someone and you don't have your patient's consent, I would pick up the phone to MPS and just take that moment to ask and make sure you're doing the right thing. Because, of course, once information's been released, it's done. You can't get it back.
Yeah.
And the other common scenario that we get is the police contacting, for example, the GP surgery and saying, can you please give us information? We believe this person was involved in an assault and we want to know if they present with any injuries. And again, contacting us and getting advice on the appropriate way of handling that situation is the right thing to do.
Yeah, absolutely.
Because although, as I understand it, we have a discretion to release under certain circumstances, that could still be protested in front of the Privacy Commissioner, and we'd have to be able to show very clear reasons as to why we chose that course of action. And
in those situations, there are easy cases where it just seems abundantly clear that the right thing to do is to exercise your discretion to assist the police by providing them with some information. And then there are other times where we say, look, just make the police jump through the hoop of issuing you with a production order, because once they've done that, you can't get in trouble for responding to it. And it just takes you out of the zone of uncertainty where you're exercising a discretion and into a zone where you're just doing what you've been told.
Absolutely. And then another question we often get asked is, so the doctor's told that there's going to be a court hearing that they need to present, and they might be on holiday for that time, or they might be a sole practitioner, so that would mean that that they close down their practice and they can't work. What would you advise for these kinds of scenarios?
Yeah, I guess the scenario really is receiving a subpoena out of the blue that says you're being summoned to, well, in the criminal context, it would be a summons rather than a subpoena, but you're being summoned to appear at a certain date and time at court for the purposes of a trial. I think it's another one of those moments to call MPS. It is something you could navigate by yourself, but it can be a bit sort of hard to understand who all the players are and who the right people are to speak with, and it can be a lot easier having someone to do that legwork for you.
Yeah.
But the sort of assistance we can provide is to make contact with the party who's issued the summons. That would typically be the prosecution that have called the doctor, and we can raise issues around availability. We can often the day you've been summoned to appear won't really need to. It's not the actual day you need to give your evidence. They just summons you to appear at the beginning of the trial, and we can negotiate that you don't actually need to turn up on that morning. In fact, it's the Wednesday of the week following that you're more likely to be needed. We can work around your schedule sometimes, and the court will try to accommodate a time when you are available. If you're away doing a locum in Australia, we can perhaps even see whether giving you evidence by video is an option. There are all sorts of things we can do, but the prosecution are often pretty busy and not they're focused on winning their case. They're not focused on making all of their witnesses feel good about it. So having somebody else who's actually focused on you and what you need, and who can also talk to you about, okay, you've never been to court before, what is it going to look and feel like? What are some things to remember for the process? All of that, I think, can be helpful, and they're pretty frequent conversations that we have with members who are surprised by receiving a document that tells them they need to come to court.
And of course, for most doctors, appearing in court is a one-off or a very rare occurrence, so it's totally out of our comfort zone.
Absolutely.
And totally in the lawyer's comfort zone. Of course, that's their territory. So, getting the appropriate advice is very sound.
I often do say to members that, you don't need to feel bad about it. This is something that's, completely new to you, and that, feelings of anxiety, etc., are very expected. It would be if I walked into Chow Yen's operating theatre and she handed me some sort of machine that was keeping someone alive and told me to keep an eye on it, I would have very, very deep feelings of panic.
But I'll be back soon.
we were talking about imposter syndrome in another podcast, and that's pretty much the definition, really, of imposter syndrome.
All right, well, that brings us to the end of our podcast. Any final comments?
No, I think I'd come back to the original things that we're talking about, is that the critical bit, even though there may be a court case coming at some stage, the critical bit is to focus on the clinical aspects and to make the appropriate courting from a clinical point of view. And then maybe if you know it's going to court, you might want to think, is this complete enough that I can use as basis for a statement that will be really robust in court? And you might want to think about a few extra things to add, but focus on the clinical aspects primarily.
Yeah, and I guess I'd say that we've only had time to scratch the surface, but obviously there is a lot of good information out there. One of the things we talked about today was the ACEM policy, and if there are any listeners who are working in an ED environment, that's probably a really good place to start, just to, if you are still got further questions or unpacking some of what you've heard today, maybe go and have a read of that. It may well be helpful.
Yeah. So thanks both for joining me, and thank you for listening to this podcast. I hope it's been helpful. Our podcasts provide information of a general nature, So if you would like advice on a specific case and you are our member, please contact us on 0800 22 55 677, option 3, during business hours. We look forward to catching up with you in our next podcast. If you like the Medical Protection podcasts, please subscribe and leave a review. If you would like a podcast on a specific topic, please email nzpodcasts@medicalprotection.org.